a very warm welcome to everyone to the Scale Neonatology virtual Grand Round. And for those of you who are new to joining the Grand Round, Scale Neonatology is a collaborative between the UK and the Ugandan Health Alliance. And we have a series of neonatal Grand Rounds where we have presentations from both Uganda and the UK. And it's all about shared learning, collaboration, and just sharing ideas about how we can manage our little babies in the hospitals. The topics that we've chosen are quite key to both us in the UK and Uganda, and I think you'll see this from today's talk. There is a chat function, so please feel free to put in questions and we will attempt to answer them as we go along. The teaching is being recorded, so if you don't want your face on a recording, then please turn your camera off. But these are available for people afterwards to look. We have over 270 people registered, but we know that not everybody will be online. But generally, we average about 120 to 150 participants. So it's a great learning opportunity, and it's just great to share with our colleagues in Uganda about the management of common conditions that we see in neonatology. The topic today is about non-invasive ventilatory support. So we have two case presentations. We've got Dr. Amir going first from Harrogate, which is in West Yorkshire, and Harrogate local maternity and neonatal system. And he's going to be talking about the use of CPAP and the difference between CPAP and high flow. And then I'm going to hand over to Dr. Martha and Mary and Kathy from Mbale in Uganda, and they're going to be talking about CPAP in Uganda. So welcome, everybody. Please feel free, as I said, to use the chat function. And Dr. Amir, you're very welcome, and I'll let you start. Thank you.
Good afternoon, everyone, and thank you for the opportunity to present at today's Grand Round. My name is Mohamed, and I am a Paediatric Registrar working at Harrogate District Hospital. Today, I will be discussing the role of continuous positive airway pressure in the management of RDS, with particular focus on challenges faced when CPAP is not available. As Harrogate Hospital is level 1, a special care baby unit, and we don't have the facility to provide CPAP, which is typically initiated in level 2 or level 3 neonatal units in UK. So I will, in this presentation, I will share the real case from our unit where high flow nasal cannula was used as an alternative to CPAP in a preterm infant with RDS. Following the case, I will discuss the key aspect of CPAP management, including indication, contraindication, initial settings, and safe weaning of CPAP. So the case we had in Harrogate were a twins, MCDA twins, female twins born on 4th of March 2025, with a gestational age of 36 weeks, born after elective CS. Twin 2, I particularly speak about twin 2, born with birth weight is 2.6 kilogram at level 1 special care baby unit, as I said. Maternal background, we had a high BMI, more than 45, and no risk factor of sepsis. And parent declined use of steroid before the delivery. So in theater, twin 2 was born in poor condition with poor respiratory effort and heart rate less than 60. So she required 2 sets of inflation breaths, followed by gradual improvement of ventilation and gradual improvement of heart rate, but she needs to be kept on beep and FI2 of 60 to 80% to maintain saturation. After 45-minute observation in theater, we decided to admit the twins to special care baby unit. And we started on high flow nasal cannula, setting of 7-liter flow and FI2 around 60%. So in SCABU, the differential diagnosis we had is RDS versus TTN because the respiratory rate was more than 75. But the X-ray, as you can see, is suggestive of RDS. So serial blood gas done in the first few hours of life, which showed mild to moderate respiratory acidosis with BCO2 up to 9.1 in the first few hours of life. And actually, because we are level 1, our rule here is stabilize the preterm or babies who needs high flow or even ventilation till we manage to transfer them to level 2 or level 3 tertiary unit. But if we believe that babies can stay for about 24 hours, 48 hours on high flow, and we can easily wean them from high flow. So to avoid parental separation, we can keep them even being off pathway in our units. And otherwise, if they deteriorate or increase oxygen requirement, we will think about transferring them to level 2 or level 3. So we normally have like a daily MDT discussion and updating the Embrace team, which is neonatal transport team, and discussion with the tertiary units as well. So the plan was to continue monitoring of the twins and do like 4 to 6 hourly gases in the first few days of life and frequent clinical assessment. If they deteriorated or oxygen requirement goes up more than 30%, is to consider transfer. So initially, the FI2 was fluctuating around 30%. So we were very optimistic because they are 36 weeks and FI2 is around 30. We're very optimistic that we might wean them soon from high flow. So that's why we kept them in our unit. But we also discussed the surfactant therapy after having this X-ray and initial blood gases. But being, again, in level 1 special care baby unit, we were unable to give LISA, which is less invasive surfactant administration technique. It's also used in tertiary levels. We also thought about Ensure technique, which is intubation, surfactant administration, and then extubation. But again, because of level 1 special care baby unit, we couldn't do that. Actually, that was related to a lack of sedation. So we don't have propofol, which is short-acting sedation. We just have fentanyl and trachorium. So that means we need to keep the baby on ventilator for a while. So we didn't go through the surfactant administration for the twins. And we thought that they are improving, and FI2 was around 30, as I say. However, they remain on high flow for longer than usual here in our unit. So we kept them nearly 5 days on high flow with a slowly weaning of FI2. And they start showing gradual improvement, and we weaned twin 2 at day 6 of life. So finally, the gradual weaning of FI2 and the high flow nasal cannula was successful, and they remained for a couple of days after weaning to establish feeding, and we didn't need to escalate the cases to level 2 or level 3 neonatal unit, and they've been discharged in well condition with neurological and hemodynamically stable. So the question was, would yearly CPAP have reduced oxygen requirement and decrease the duration of admission for these twins? And the answer is likely yes. So according to NICE guidelines, the using of CPAP in the first few hours of life can, especially if they require more than 30% FI2, that can decrease the duration of admission. And the second question, could surfactant via Ensure have been attempted early? Yes, and the answer, if the baby remain on FI2 more than 30% on CPAP or even high flow, early surfactant is advisable. So based on NICE recommendation, early surfactant within a window of 2 to 6 hours in babies with RDS who require increased oxygen or ventilative support, we can start as early as within the window time. So here's a quick overview on the pathophysiology of RDS. So RDS, as we know, is happening due to insufficient surfactant production by type 2 alveolar cells. So decreasing or reduction of surfactant will increase the surface tension and preventing alveolar collapse, and that will happen during exhalation. So low surfactant will increase surface tension, as I said, and that will lead to alveolar collapse and by ventilation, perfusion mismatch, hypoxemia, and increased work of breathing. So the role of CPAP in RDS. So CPAP will provide positive airway pressure, and that prevent alveolar collapse by recruiting and stabilizing alveoli and increasing functional residual capacity, also reducing work of breathing and improve oxygenation as the end result. And here, when we consider CPAP, or what are indications of CPAP, so CPAP should be considered in neonatal presenting with respiratory distress syndrome. This is a common presentation or common use of CPAP. Also TTN. But anyhow, other condition associated with impaired oxygenation or lung compliance can get benefit from CPAP, such as persistent hypoxemia or hypercapnia. And any preterm infant with surfactant deficiency, particularly those born before 32 weeks gestation, will get good benefit from CPAP. Also, as a transition or step down from ventilation, so post-extubation CPAP for a short period, so we can step down to low flow oxygen. Meconium aspiration syndrome is one of indication of CPAP as well. And contraindication of CPAP. Just do this. The congenital airway malformation, such as congenital diaphragmatic hernia, as you know, CPAP will increase intra-abdominal pressure, and that will worsen the hernia condition. On the other hand, also having gastric content intrathoracic, that will cause pressure on the lung and leading to pulmonary hypoplasia and small size lung on the affected site. So giving air pressure can increase the risk factor of pneumothorax in this site. Cleft palate is contraindicated as well, because the ear lake we will have if we start CPAP on cleft palate using a face mask or nasal mask CPAP. Choanal atresia, unilateral or even bilateral, even unilateral, because that will affect the delivery of positive pressure. Hypotension or severe cardiorespiratory instability, because CPAP can decrease blood pressure, so that will make it worse. Poor respiratory drive. We normally use CPAP for babies who spontaneously breathing with RDS, but we can't use it with babies who have poor respiratory drive. And again, repaired gastroschisis, because that will increase intra-abdominal pressure and gastroschisis get worse. Initial setting of CPAP. So starting pressure of CPAP, it depends on the clinical condition, size of infant, and the prematurity, the gestational age. So initial setting usually around 4 to 6 centimeter H2O, which is the standard initial setting, especially with RDS or TTN. And if more support is needed, we can gradually increase the beep by 1 to 2 centimeter to reach maximum of 10 to 8 centimeter H2O. And the target of saturation is to be maintained between 90 to 95. And we start with FI2 usually around 30 to 40. Actually, it depends on what is the oxygen requirement prior to the CPAP, but I will start with 30 and gradually increase FI2 in steps of 5% to reach maximum 70 to 80%. And that would depend on the clinical assessment and frequent blood gases we're doing initially when we start CPAP. The criteria of weaning from CPAP. So actually, if baby become more stable on CPAP with good saturation, 90 to 95 without supplemental oxygen, and they don't show any signs of respiratory distress like a grunting, tachypnea, or subcostal recessions, and also reduction of apnea if we are treating apnea of prematurity with RDS with CPAP. So in case of apnea of prematurity, if the apneic episodes been stopped or even become less frequent and shorter in time, we can think about weaning CPAP at that time. A stable respiratory rate and stable oxygen requirement less than 30%. The weaning or safe weaning process, we gradually reduce the CPAP pressure increments of 1 to 2 centimeter every 12 to 24 hours, depends on the infant response and clinical assessment and blood gas. So normally if we decrease the CPAP pressure, we consider doing blood gas 1 to 2 hours after any change to settings. A common approach is to start reducing from 7 to 8 centimeter H2O down to 5 to 6 centimeter H2O, followed by a trial of CPAP off. So a trial without CPAP, if the infants maintain adequate saturation, being stable without CPAP, we consider a trial without CPAP for a period between 4 to 6 hours. If they did okay, did well, CPAP can be discontinued and infant should be monitored closely after weaning of CPAP. We can wean them to low flow if needed. Pros of CPAP. So as you can see, CPAP is non-invasive procedure in comparison with using ventilator. So ventilator can lead to ventilator-associated pneumonia and ventilator-induced lung injury. CPAP also improve oxygenation with using high pressure CPAP and also improving the FRC. Reduce work of breathing as a consequence of this, and also CPAP promoting lung development in preterm infants. And finally, the cost-effective and wide availability of CPAP, especially in a resource-limited setting. And cons of CPAP, it actually requires skilled monitoring, so it requires skilled nurse, skilled doctor to look after babies on CPAP. Make sure that the pressure is within normal range to avoid over pressurized, which can cause bar trauma. It can be uncomfortable for babies, especially as big baby. We normally fight with CPAP. Also, it can be discomfort because of the nasal CPAP can cause nasal trauma or skin breakdown caused by CPAP bronchs or mask, especially if need long time of admission. Risk of ear leak. CPAP can cause nasal ear leak and can cause pneumothorax as known complication. Finally, parental anxiety. So the sight of the tube and the machines also may distress parents. And here is comparison between high flow nasal cannula and CPAP. So from mechanism point of view, high flow nasal cannula, we're using heated humidified flow, while CPAP we rely on positive pressure. The high flow nasal cannula pressure is variable, while in CPAP it's consistent pressure used. And high flow nasal cannula can be used in mild to moderate respiratory distress, while CPAP is better to be used in moderate to severe respiratory distress. High flow nasal cannula can be easily set up, while the CPAP is more complex and need a lot of arrangement. And as I said, needs also expert nurse and doctors look after the baby. High flow nasal cannula is considered gentle and non-invasive technique and well tolerated by most of babies, while CPAP may cause complications such as nasal trauma, skin breakdown, pneumothorax. The efficacy of high flow nasal cannula in comparison with CPAP, it's less alveolar recruitment if we used high flow nasal cannula, while in CPAP it's more effective lung expansion-wise. And here are the clinical guidelines and reference I've been used for this presentation. And finally, thank you. And if any questions, I'm happy to answer.
Amir, thanks for a fantastic presentation. At least our team here, really interesting to see the similarities already and the differences between the two settings. I think that will become more apparent as we listen to the next presentation. So thank you very much, Amir, for taking us through that. It's a pleasure today to introduce two members of the Mbale Neonatal Unit team. We have Dr. Muduwa, who's one of our neonatal medical officers here in Mbale, and also Sister Mary Alebo, who is one of our neonatal nurses. Here we don't have high flow, we use bubble CPAP. And so our presentation today will focus on RDS and CPAP. There may be a little bit of overlap with what we've already heard, but I think that this is quite a new area for many of us, at least here in Uganda. And I think that that will help us consolidate our learning today. And then we'll go on to a case of a preterm who was managed here with CPAP in Mbale Regional Referral Hospital. So go ahead, Martha and Mary. Thank you.
Thank you very much. I am Martha Muduwa, Medical Officer Neonatal Unit. It's an honor to be presenting at the Scale Grand Rounds for a second time. Okay, so we're going to look at safe use of CPAP in a low resource setting. So our objectives today, we want to understand what respiratory distress syndrome is. Dr. Amir has already said some of that. We'll discuss the management of RDS, we'll understand what CPAP is, the evidence of use of CPAP, and also then we'll look at a case that Mary here will present. Okay, so just for a clear picture, globally, neonatal deaths account to about half of deaths under 5, and of those deaths, which is about 24 million newborn deaths every year. Of those, the majority of the deaths are in preterms, and they're due to preterm complications. To note is that respiratory distress syndrome, which we're looking at today, is the leading cause of preterm deaths. Okay, so respiratory distress syndrome, when a baby is born too soon, or when they're too small, they can have difficulty in breathing. As you can see in that video, we have a baby who has labored breathing, they have subcostal recessions, sternal recessions, they're tachypnic, and they also have they're struggling to breathe, basically. So that's a baby with distress. That's what they'd look like. They will also have grunting, which you could hear with or without a stethoscope. They could also have nasal flaring, and there's also need for increased FiO2. So they have higher requirements of oxygen. I'll explain a bit more about the FiO2 a bit later and further down in the slides. So as Dr. Amir had mentioned earlier, RDS is because of the deficiency of surfactant in the preterm infants. So just to break it down a bit more, a lung without surfactant or an alveoli without surfactant is kind of like blowing into a new balloon, or a very small and new balloon. So with every breath, you need a lot of effort to inflate this balloon. However, if you have surfactant, then at expiration, there'll be a bit of air that's left in the lung, and this allows also for ease to refill the lung at the next breath. So a preterm without surfactant has there's increased surface tension in that lung. So that means that every single time that they breathe out, the alveoli will collapse on themselves. So that's the atelectasis that we can see here on our flowchart. And when you have the collapse of the alveoli, then you'll have a ventilation perfusion mismatch. So you are breathing in, but the air is actually not being exchanged at the alveoli because they're already collapsed, or a majority of them are collapsed. And this will increase your work of breathing. But also you'll have some of the carbon dioxide being retained in the alveoli, and very little exchange happening, like we've mentioned, because of the ventilation perfusion mismatch. So that will result in hypercapnia because you're retaining a lot of oxygen, and this will in turn cause acidosis. Then also because of the increased surface tension, you have hypoxemia, and acidosis, which has resulted from what we've just described, will increase the pulmonary vascular resistance. And then you'll have a right to left shunt, and that means you just keep worsening this cycle of acidosis. So what you want to prevent during treatment of RDS, or what your goal is in a place where we cannot measure the blood gases, like in our setting, is you want to prevent hypoxemia and you want to prevent acidosis, because these are the ones that will lead to worsening of your baby's condition and maybe death of the child as well. So this is what I've been describing. So this is a normal alveoli. You have your oxygen in and the exchange is happening and the carbon dioxide goes out. While when you have a collapsed lung, you have much less of the gaseous exchange happening at the alveoli since it is collapsed. So you start shunting blood away from the collapsed alveoli, and then that just worsens the acidosis that we had mentioned earlier. So RDS affects infants under 34 weeks. So that's preterm infants that we had mentioned, and it's worse with decreased weight, or it's also worse with a lower gestation age. So as you can see with this graph, the smaller you are, the higher your incidence of RDS. So if a baby is 751 grams, then they have about a 79% incidence of RDS in that group. So the smaller you are, the younger you are, the earlier you're born, the higher your chances of developing RDS. So other risk factors that we can look at are if you're a male, unfortunately, elective C-sections, perinatal asphyxia, Caucasian race, and infant of a diabetic mother, and chorioamnionitis. These are also factors that worsen or increase the risk of so many other preterm complications. Interestingly, there are some factors that decrease the risk. So in infants who are IUGR, with prolonged rupture of membranes, maternal hypertension, and the use of antenatal corticosteroids. So with these other ones, the mechanism is not so clear, but mostly it's related to the stress that the fetus is undergoing just before delivery. It increases the production of their production of corticosteroids and fastens their lung maturity. So it's the stress that is reducing their risk. However, it still puts them at risk of other complications. So antenatal corticosteroids are very important, and that should be really something we should focus on with all mothers in preterm labor, because they not only reduce the risk of RDS, but ROP, retinopathy of prematurity, intracranial, ventricular hemorrhage, PDAs, and so many other preterm complications can be reduced by administering antenatal corticosteroids. So what are the goals of management? Our goals of management for RDS are, like I mentioned earlier, avoid hypoxia. So you want to monitor these oxygen saturations. And you also want to avoid acidosis. So in a condition where you cannot measure, like Dr. Amir was mentioning, being able to measure the blood gases, you need to really avoid getting to the point where you have to look at this. So we also have to optimize fluid management. You do not want to give too much, so don't overload, because you can cause pulmonary edema. And then you also do not want your baby to go into hypovolemia or hypotension. So you should just give enough, so the right amount at the right rate, and also to maximize nutrition. So breast milk has been found to have so many benefits, and it also is of benefit in infants or preterm infants with respiratory distress syndrome. So the earlier you start to feed, the better your chances of recovery. Then also to minimize disability. So we do not want to save so many babies only for them to be blind because of retinopathy of prematurity. So minimizing disability is a very, very big part in the management of RDS because of some other reasons that we'll mention down the presentation. So how do we manage RDS? We've mentioned the most important is to prevent. So we've mentioned antenatal corticosteroids like dexamethasone, then use of CPAP, and then surfactant is also very important in this. So we've had a decrease in morbidity and mortality in high income settings with those treatments, that is CPAP, artificial surfactant, and the steroids. But RDS is still a very big problem in our setting, like in Uganda and other low resource settings. So let's now move on to talk about CPAP. So CPAP is continuous positive airway pressure, and it's just the definition of what CPAP is. So babies who have respiratory distress, the baby we've just mentioned above, and like a baby in this video here, they need support that is beyond oxygen. So here are some sources of oxygen that you would find commonly in our setting. So you can have concentrators, you can have oxygen cylinders, And oftentimes, because you do not have so many of these, this is how we end up sharing out some of our oxygen. So you can have an empty fluid bottle with different connections. You can have Y connectors. You can also have flow splitters. So the challenge with using this setup of having an empty fluid bottle is if one of these pops off, then all the other babies are not getting any oxygen. And sometimes it may take a while before someone notices that there's been a disconnection, similar to the Y connectors on the floor. Someone puts a stool over it, then the tubing is all blocked and you're not giving any oxygen. So the best way to share the oxygen would be using flow splitters. This is an affordable way that you can have one concentrator or one cylinder running for more than one baby. And this is also really important because you can regulate how much oxygen each infant is getting, and you're sure of how much you're giving to each baby according to their need. So this is, if not the most important thing that we should see today. This is a lung of a rabbit with CPAP. So this is without CPAP. So as you can see, there is a lot of collapsed lung. And every time there is expiration, the lung almost completely collapses. And you have a lot of collapsed lung even at inspiration. So now this is with CPAP added to the lung. And every single breath, you have more and more of the collapsed lung being inflated. And at expiration, you do not have collapsing of the lung. So this is what CPAP basically does. So for any patient that's on CPAP, let's keep this image in mind and avoid interruption of their treatment. And this is the same lung now with the CPAP removed. Okay. So this is what the setup of a CPAP would look like. You have your oxygen or air source. So ideally, or it should be, you should be able to blend your oxygen and air. So we have an oxygen and air blender. It can be a concentrator, or it can be a device that delivers mixed air and oxygen. And so you have your inspiratory tube that comes to the baby. This is where your baby is at, the patient interface. And then you have, so when the baby takes a breath in, what they are getting is what's coming from this source. And then when they take a breath out, the air does not completely escape. It stays within this closed tube all the way to the pressure chamber. So they are breathing against this pressure that you have preset. So the depth that your tube is down into this pressure chamber is what determines the pressure that you're actually delivering to the baby. And your water column. Okay, so here is a very clear example of how good CPAP can be. Here we have a baby with severe subcostal recession. There's increased work of breathing. They're really not doing well. And this is the same baby just 5 minutes after CPAP has been initiated. So let's just remember the image of the rabbit and the lungs. Okay, so there are some studies that have been done, a systematic review that was done in low and middle income countries, mostly looking at observational studies that were in Fiji, South Africa, and Malawi, showed that with introduction of CPAP in those low resource settings, there was a decrease of 66% reduction in in-hospital mortality in the preterm infants. So that shows how efficient CPAP can be in reducing mortality of these infants. So here are some examples of our low-cost CPAPs that are available in our setting. We have the Punani, I think it's called Punami, the Pumani, the Pumani CPAP. And this runs in a concentrator, so all these need external sources of oxygen. Then we also have the Vayu CPAP, that also requires an external source of oxygen. You're able to blend oxygen with both these two. And then you have the Diamedica CPAP. So this is the CPAP that we use in Mbale. So this is a concentrator essentially that has, you have two dials, the one of oxygen and air, and you're able to blend. And this is our pressure chamber over here and our humidifier. Okay, so locally we had some research that was done in our neonatal unit, and this compared two periods: a period before introduction of the low-cost CPAP, the Diamedica that I mentioned, and the period after the introduction of the CPAP. And we found that with introduction of this low-cost CPAP locally here, we reduced our deaths of preterm infants, so very low birth weight infants, by almost half. So before we had about 50% of them dying, and that was reduced down to 27% with the introduction of CPAP. And I believe with further improvement in the neonatal care, those numbers keep going down. So this is our guideline on how we initiate CPAP. Some of this has been mentioned by Dr. Amir. I'll just elaborate some of the bits. So when you have your baby, like all those videos that we've seen, you've assessed them and they need CPAP. So for us, we use a down score to give an assessment. And if your down score is more than 4, and the baby has an increased need of FiO2, so they have increased need for oxygen, so requiring a higher FiO2, you would start them to maintain the target SpO2 of 90 to 93%. You would start your CPAP, ideally at a pressure of 5%, so 5 centimeters. So we start at 5 centimeters and we give 4 liters of oxygen and 4 liters of air. So this is titrated depending on the baby's need. If your baby is already saturating above the 90s, then you can adjust this accordingly. So then you monitor your baby. Monitoring is very important in CPAP. You monitor your baby and check for signs of improvement. If the down score is going down, reduction of oxygen requirement, and there's visibly reduced signs of distress, like we saw in the baby who was initiated on CPAP, you would reduce on the requirement of the CPAP. So if they were at 5, you can go down to 4 and monitor them and still continue like that. However, if you have signs of failure of CPAP, your downs is just increasing, quite the opposite of the signs of improvement. Baby is having apneas, the distress is just worsening even when they're at the maximum pressure, then you need to go and check. So you check that your CPAP is properly working, you check that you've set it up properly, check that there is no interruption at any of the tubes. Check that your tubes are not broken, that your water level is at the right place. It's the basic thing to start with before moving further. Then if there is sudden change still, you've checked all these things and they're normal, then you should suspect that there is maybe a pneumothorax, especially if you had a child who was improving and there's sudden worsening of their distress, then you need to check for a pneumothorax. So in our unit, we are able to do bedside lung ultrasounds, and that would rule out your pneumothorax quite easily without having to move the baby. So if you have a pneumothorax, then you need to drain it. If you do not have a pneumothorax, then you increase the pressures and then you continue with the monitoring as before. So another aspect that we looked at nutrition. We also need to look at thermoregulation. So when your baby is cold, they have a very high metabolic demand. And the higher the metabolic demand, the more the oxygen that you need. And this is a baby that's already struggling to get their oxygen saturations up. So if you want to improve the outcome of these babies, like we said, we have to prevent hypoxemia. You need to keep the baby warm. And we use kangaroo in our unit. Here's a picture of a mother from our unit doing kangaroo care. So we need to thermoregulate to support on our CPAP. So other treatments for RDS like surfactant and mechanical ventilation. Surfactant is inhibitively expensive. In our unit, maybe in a year, you could have 1 baby receiving surfactant because of the cost. So we very rarely or almost never use surfactant because of the cost. Mechanical ventilation is equally the same. There is very few units or none in a government setting that have mechanical ventilation. So we want to avoid reaching this point of need of mechanical ventilation. Some of the ways that have been found to do that are with immediate or early CPAP. So initiating of CPAP within the first few minutes of delivery, targeting 15 to 30 minutes right after delivery. And this has been found in high resource settings to reduce the number of, to reduce the need for mechanical ventilation. So that could also be something that we can look into in a low resource setting, since we do not have anything else if CPAP fails to work. Okay, so there's a trial that was done in mostly high resource setting, the BOOST-2 trial, that gives evidence for the targets of oxygen that we use or that we aim for in our unit. So there was a comparison of 2 groups. We had a lower target group, which kept a target of 85 to 89%. and a higher target group, which was 91 to 95%. So these were the lower, the lower target group was the previous recommendations. When the two groups were compared after 2 years, we found that there was, in the group with the higher target, you had a reduction in mortality than as compared to the one of lower target, which is 85 to 89%. So these infants, more of them survived with a higher target of oxygen of 91 to 95, and we did not increase, there was no increased risk of complications or there were there was not a bigger number of babies with blindness or ROP because of the higher target of 91 to 95. So it was found to be safe. So that's the target that we go for. So just to explain a bit what FiO2 is, so it's the fraction of inspired oxygen. Like I mentioned, with our Diamedica machines, we aim for a total of 8. So that's the mixture of oxygen and air should be at a total of 8. So if I'm to just give an example, as you titrate and mix the oxygen and the air, you reduce the FiO2 that the baby is reducing. And your aim is really to give maximum support with the lowest FiO2. So if you can maintain an FiO2 that is low, and still keep the saturations at 91 to 95, then you are actually doing a good job of helping this baby. So I'll give an example. If you're giving oxygen, we're assuming that our oxygen here with this chart is at 95%. If you're giving oxygen of 4 liters and 4 liters of air, like in this, like our setting that I told you we start with, you'll be giving an FiO2 of about 57.5%. So your goal, like I said, should be to give the lowest FiO2 that is able to maintain your saturation with 91 to 95%. So these are your target oxygen saturations. So you take note that with preterm care, you need to have a lot of monitoring, continuous monitoring if possible. Which is usually a challenge for us, but we need to really think about it as we try to manage smaller and smaller babies in our different settings. So this is the target saturation for a preterm infant at different minutes of birth. So at 1 minute, that should be your target. If this is not a baby that requires oxygen, a baby below 60 would require oxygen, and at 5 minutes, it's that. So this should be a good guide. So you can add oxygen and transfer the baby on oxygen as required, depending on their saturations with continuous monitoring. So some complications of CPAP, the major complication that we see or that we have to deal with here is nasoseptal erosions that had been mentioned earlier. But there is a lot of techniques and different techniques that we can use to try and prevent this. So this is our staging. This is the staging for nasoseptal erosions. You can have a grade 0, which is none, up to grade 3, where you have septal necrosis. So a baby on CPAP should be checked every single day. You should examine them for nasoseptal erosion and grade accordingly and intervene if you find the nasoseptal erosion. So this is what nasoseptal erosions would look like. So this is a grade 1, you just have a bit of erythema. A grade 2, you have some superficial erosion, and a grade 3, you have a full skin thickness erosion, also with necrosis in severe cases. So this is how you can prevent this is how you can prevent nasoseptal erosion. So first of all, the tubes that you pick should be the right size. So your cannulae that you're using for CPAP should be the right size. It should cover about 80% of the nostrils of the baby. You should take note that there should be some space between the septum and the cannulae. So your cannulae should not sit on the septum of the baby, otherwise those are too small. And then the prongs should also be inserted facing downwards. They should curve downwards and should also ensure proper positioning of the infant when you're using the CPAP. So after you've set up your CPAP, you need to check that it is actually working well before you put your infant on. And we check this by closing the circuit completely. So you make a closed circuit, cover the nasal prongs, and then you should see bubbling in the pressure chamber. That should confirm that your CPAP is properly set up. So I saw some comments about homemade CPAP in the pre-session assessment. So homemade CPAP, as we've looked at all these, the tubing that is being used, the corrugated tubing that is being used, the cannulae, all these things are preset, they're tested, and they're found to be safe. So those tubes are found to deliver. If you've set a pressure of 6, you are delivering a pressure of 6. However, the challenge with our homemade CPAPs is, and also we mentioned a lot of the need for continuous monitoring and the need for blending of oxygen. So when we look at most of the homemade CPAPs that are used in our settings, you find that you're not certain of the depth of submersion. You cannot measure the pressure that you're giving. Then the tubes, which we often use, are very small, and smaller tubes will give you there will be increased dead space in the setup that you've made, and you're not able to measure the amount of dead space, and this could worsen the respiratory failure. The narrow tubes have high resistance, and high resistance will just increase the work of breathing that the infant has to breathe against the pressure that you've set. That is also not properly well determined. Also, there is the risk of retinopathy or prematurity because of the use of unblended oxygen. So most times we will run these homemade CPAPs off of a cylinder. So these are highly discouraged. There is not enough evidence to support their use. So it's better to send a baby to a place that has proper CPAPs if you are unable, if you do not have them, rather than trying out with the homemade CPAPs. Yes, so we're going to move on to the case that Mary will present.
Thanks so much. Good evening, colleagues. Thanks so much, Dr. Martha, for taking us through that. I have a case that I'm going to present of a baby who was managed in our unit using a CPAP. So I have a mother by the name AS, and she's a 39-year-old mother who had both HIV and syphilis tests negative. She was a gravida 9 para 8+1 with no previous preterm infants, but had one stillbirth. Her mother had a preterm premature rupture of membranes. And then the last menstrual period was 3rd of September 2003. The gestational age, as calculated, was 29 weeks. The baby was delivered through cesarean section due to severe oligohydramnios, and the baby did not receive dexamethasone. I mean, the mother did not receive dexamethasone. So the baby was admitted in our neonatal unit, and it was a female infant which was delivered at 14:46 on the 25th of March 2024, and weighing 925 grams, requiring 6, 7, and 8. No resuscitation was done. Vitamin K and tetracycline was given. Oxygen saturations at 5 minutes was 75%. Baby was put on CPAP with 1 liter of oxygen. At 10 minutes, oxygen saturation at 86%. 15 minutes, oxygen saturation at 94%. Infant was transferred to the neonatal unit on CPAP and oxygen in transport trolley. All this was done in the delivery room. And here is one of my colleagues who is working with us, and she was ready to set the baby on CPAP. This is one of the portable CPAPs that we have in our neonatal unit. On admission, baby arrived at 15:20 hours on the same day of 25th March. Vital observations were done and they were all normal. And then we had a down score of 4. That means that our baby had moderate respiratory distress, and this was the right time for us to start our CPAP. The RBS was 2.6, which was very vital for us to do always, to check the blood sugars of our babies right on admission. The temperature was at 5.7. That meant that our baby was cold, and then it needed us to do kangaroo mother care. but at this point, there was no one. The immediate treatment that was given to the baby on admission, baby was loaded with caffeine, 20 milligrams per kg infusion, and then cefotaxime and gentamicin were given. These are first-line antibiotics in our neonatal unit. And then the baby was started on 5% dextrose, 100 mils per kg per day. And then the kangaroo mother care was provided, this time by the father. The father turned up after a few minutes after attending to the mother from the delivery room, and then the bubble CPAP was started within 1 hour of delivery at 5 centimeters of pressure, 4 liters oxygen, and then 4 liters of air. And then the first day, day one, our baby was reviewed at 18:53 hours. Temperature was taken, heart rate, respiratory rate, and the baby had moderate hypothermia. When you look at our temperature there, our SpO2 had picked up to 97 on bubble CPAP with those settings of 5 centimeters, pressure, 4 liters oxygen, and 4 liters of air. So the down score here reduced up to 2. Maybe just to add on that down score, this is just a clinical tool that we use to assess the level of respiratory distress in our newborns or in neonates, mainly the preterm babies, before you start the baby on a CPAP. So the baby was examined on that very day one. The baby was pink, well hydrated with reduced activity, reduced movement, fontanelle was normal, mild recessions, reduced air entry bilaterally. The chest was clear, no grunting. Heart sounds were normal, abdomen fullness normal, soft cord clean and well ligated. The impression here, the doctor said extremely low birth weight, with sepsis and moderate hypothermia and mild respiratory distress. The plan of management was to continue KMC, reduce the FiO2, and then those were the settings of CPAP that the baby was put on, and we continue antibiotics, continue with the fluids as well. Day one, the investigations were done, and Dr. Martha is going to take us through the investigations.
Yes, so these were our investigations that we did. We do cranial ultrasounds on day 1 and day 7 and 28. So this is our cranial ultrasound, and it was normal. We're looking for IVH. There was no IVH seen. Then this is the lung ultrasound. So this first bit shows complete whiteout of the lung, which would be a sign of distress. And this is a normal lung. So you have the A lines, which are those nice lines running horizontally. But in a baby with respiratory distress, you have complete whiteout. So these are very many B lines showing that there is collapse of the lung at those points.
Thanks so much, Dr. Martha. Day one, still the assessment was done. Mainly the vital observations were taken at 8:30. So actually, when you look at those vital observations, our baby was improving. The SpO2 was at 97, heart rate was okay. Our respiratory rate was fine, and our down score had decreased to 2. That means that the respiratory distress was mild at this point. And then our CPAP settings, here now we had to decrease the oxygen, and then we increase the air that we are giving, because our machines run at 8 liters. Then the vitals at 10:50. Still, our baby was doing well. The SpO2 was good. The down score here reduced to 0. And these were the settings that we put for the baby. On day 2, our baby, when you look at the vital observations that were done, our baby became cold a bit. Actually, the baby was cold, and the baby was put on KMC. The heart rate was fine. The respiratory rate was that, and then 98% oxygen. So That meant that our baby was still doing well here. On examination, there was mild subcostal recessions, otherwise it was normal. Then the plan of management on that day was to reduce the CPAP pressure and the FiO2 to 3 centimeters of pressure, 0 liters of oxygen, and 8 liters of air. Because at this point, our baby was saturating well, there was no need for high amounts of oxygen. And then we had to continue with the antibiotics. And then the caffeine to prevent the apneas of prematurity, the dextrose, 5%, so that we keep the baby hydrated. The KMC had to continue, and then the lactational support. As Dr. Martha had explained earlier, the nutrition also is very paramount in improving the respiratory distress. So this baby, the baby was started on 2 meals of donor human milk, 25 mils per kg per day, every 2 hours using a nasogastric tube. We had to continue maintaining the warmth of our baby. Remember in the previous slide, the baby was cold. So here, we had to continue with the KMC, and the mother was actually encouraged to continue doing the kangaroo. The nutritional support is very key in the management of RDS. And at this point, her mother was found to be unwell with no breast milk. So we had lactational consultation with our breastfeeding specialist, and the baby was started on the human donor milk and continuous lactational support. On the day 3, our baby was still reviewed at 8:30. There was sudden worsening of the distress. Temperature here again went down. Our SpO2 went down. That meant that there was something not well. And then the pressure, the CPAP settings was 3 centimeters, 0 oxygen. That could have caused this hypoxia. Again, the baby's desaturating. That meant that we had to do something. The down score was 5. That means that the baby again went into severe respiratory distress. That called us to improve on the settings of the CPAP. And then the baby was diagnosed with a pneumothorax. There was no pneumothorax and consolidation in the right lung. The impression here was pneumonia. And then the plan of management, we had to change the baby in second-line antibiotics, low dose of amikacin, cefotaxime, 50 milligrams per kg. And then we had to increase the pressure, the oxygen that we're delivering to the baby with 0 air. Day 5, vital observations done. Her baby was fairly improving. The temperature was at 6.5. The respiratory rate 43. SpO2 was okay, 97. And on CPAP, we had 4 centimeters. And then 2 liters oxygen with 6 liters of air. The baby here was weighing now 0.933 from 0.925. So that means there was a problem then. The heart rate was 144. The down score was 3. Then the examination, the baby had good movements, mild subcostal recessions, good air entry with a clear chest. The plan of management was to reduce the oxygen and increase the air. Continue with the antibiotics at least for 7 days, maintain caffeine to prevent apneas, and then reduced fluids to 25 mils per kg, because now at this point, we are also giving the baby their milk.
Okay. So thank you, Mary. So we then we do screening echoes for all our very low birth weight infants. So we had a screening echo done. Here's people from the team doing an echo on a baby. So our echo showed that we had we had a normal situs and connections. Our valves and structures were normal. We had laminar flow in the great vessels, and the the ratio of the left atrium to the aortic root was 1.3 to 1, which was normal. And there was also anterograde flow in the descending aorta, and this baby did not have a PDA, so it was essentially a normal cardiac echo. So continuing days 5 to 15, this baby continued to have a normal course of treatment. However, we found on day 6 that they had a nasoseptal erosion. So to treat this, we apply petroleum jelly just to be like a barrier. And we found that it actually helps with the healing of the nasoseptal erosions. Then day 7, we had a cranial ultrasound again, which was normal. Then this baby later on went through the course of, by day 13, we started our holidays, as Dr. Amir had mentioned. We started 2-hourly holidays and weaned them off slowly of CPAP by day 15. So this is not a sudden thing. It's a gradual process of weaning of CPAP. Then they continued to have fluctuation of temperatures, but we kept encouraging kangaroo. And with time, the mother established her own milk supply, and the donor human milk was stopped. So remaining course of admission, we've reached full feeds by day 16. We started spoon feeds, we started supplements. They continued with their oral caffeine. They were immunized by day 18. We had a day 28 cranial ultrasound. There was still no IVH. And the rest of admission was not significant. So our infant continued to gain weight. And when they hit our target weight of 1.2 kilograms, we discharged them home on day 32. Yes, so thank you so much for giving us the opportunity to present.
Thank you ever so much, Dr. Martha, Sister Mary, for a very eloquent, detailed, and also incredibly clear presentation. I'm not sure that anyone can have many questions after that. But we're going to offer some. We've tried very hard to answer the questions in the chat. A few people have been sending direct message questions in the chat. And I think I would just like to highlight the responses to some of those direct questions so that everybody can benefit from those answers. And then we will open the floor to anybody who wishes to ask questions. We're still remaining with about 20 minutes. So Amir as well, Dr. Amir, if you're still there, if you would kindly put your camera back on, I think we might have some questions for you as well. I definitely have one that's come up in the chat. So I think there's lots of questions that have come to me about ROP and the dangers of homemade CPAP and ROP. And I think that that is something that is actually really terrifying for all of us. Just to give you some small amount of data from here in Mbale, we started doing ROP screening in December just last year. So we've screened actually very few. We screen all our babies who are very low birth weight, under 1,500 grams. And as you've seen, we use blended oxygen for those babies on CPAP. And we've got a 20% incidence of treatable ROP. They've all been treated, but I think it's safe to say that most of our babies running on an FiO2 of 21 or 0.21, and we still have that high incidence. If we go around and we use homemade CPAP using direct cylinders or concentrators, we're going to have a huge epidemic of childhood blindness secondary to us trying to use homemade CPAP. And like Martha has described, we don't know the pressures or the resistance in the tubes that we're using. So although we might be putting the tube 5 centimeters under, actually the resistance from the tube itself could be meaning that you're even delivering 10, 15 centimeters, you don't know. So I think as a group, at least on the Ugandan side who are attending, we really need to move towards using the low-pressed CPAPs, which are safe. So there is one question for you, Amir. Most of the questions I got were about ROP, so I just wanted to share that with everybody. So, Amir, do you use Optiflow high-flow oxygen in your level 1 neonatal unit? And if so, would you be able to share some of your experience of using Optiflow with the team?
Yes, hi. Yeah, we in our unit as level 1, we use high flow more frequent, but as I said, we're using it for stabilization first. So with mild to moderate respiratory distress, we can start babies on high flow for stabilization. And our point, our save point is when they need FI2 less than 30, so we can keep them in our unit to prevent parental separation. But if they require high FI2, and we believe that we can't wean them from high flow recently, our guidelines or policy here is transfer them to level 2 or level 3 neonatal unit. So our experience with high flow is just limited to stabilize babies in first 1 or 2 days of life on high flow if they are just mild to moderate respiratory distress, and then be transferred if they need more than 2 or 3 days or needing high FI2. But with experience in high flow, it's very more gentle in comparison with CPAP, and also complication and side effects of high flow is less in comparison with CPAP. But as I said, it's not all patients can be used. We can't use CPAP, high flow in severe respiratory distress cases.
Thank you ever so much, Dr. Amir. There was a couple of other direct messages about how do we start the pressure of CPAP and what would be the preferred FiO2. So for those who've also asked, FiO2 is the fraction of inspired oxygen, so the percentage of oxygen you're delivering via your CPAP. And many of our preterms only need room air, that's 21%. Martha, do you want to share your slide and take us through? As suggested, I think it's safe to say that everybody does it slightly differently. We saw from Dr. Amir's presentation it was 6 to 8 centimeters, but in answer to that question, maybe we could just share the protocol that is used in Mbale about the pressures and the FiO2 that we start on and how it's adjusted.
So how do we start the pressures? Like I said, first we'll start by assessing that neonate, and you get your down score that Mary alluded to as well. So you have your down score, and if your down score is greater than or equal to 4, then that's an indication for you to start the CPAP. So you'll start at a lower pressure of 5 centimeters. You'll start at 5 centimeters with 4 liters of oxygen and 4 liters of air. We mentioned that was about 50% FiO2. So when you start with this, you're going to titrate this according to the baby's saturation. So that's why I said it's very important to titrate according to your baby's saturation. So you have a monitor on and you've put your 4 liters of oxygen, 4 liters of air, and you watch this baby's saturation. If you come back and find, like we did in our case, that your baby is saturating above 95, your target is 91 to 95%. So if you find that your baby is saturating above 95, so the 96, 97, you're going to reduce on the amount of the oxygen that you're giving. So if you were at 4, you consider reducing to 2 and increasing the air to 6. This is specific for the machines that we use, and it could vary with the kind of CPAP that you're using. So if you then come back after a while and find that the baby is still saturating above 95, like we saw in our case when we reviewed on the third review, you reduce this further down to 1 liter of oxygen and 7 liters of air, and you still titrate. So it's a continuous thing. You change some of the settings and you monitor. Then for the pressure, you're going to change this according to the baby's condition. If you realize that with a 5 centimeter pressure, it's been 30 minutes, you've come back to assess your baby, and their down score is still 4, or it's increasing, it's even worse, it's maybe 5 or 6, this pressure is clearly not enough. So you need to increase the pressure. So you can increase it by 1 to 2 centimeters of water. So you increase this and then you still monitor. If your down score is still remaining high, you may need to increase the pressure all the way up to 8 to 10, and vice versa. If the down score is reducing, you then gradually reduce your pressures as well by 1 to 2 centimeters, depending on the clinical condition of the baby. Hope that answers the question.
That's great. Thank you, Martha. And maybe just add, in Mbale, we've been using clinical respiratory distress scores for maybe 7 or 8 years. So we started using down score and we still use down score. But if it sounds a little bit unfamiliar, actually in the national clinical protocols for care of the small and sick newborn, we have actually decided to put the Silverman-Anderson score in there. That's the SAS score. It's very similar, and either of them are okay to use. And essentially they have the same cutoffs. So if you've got 4 or above, you've got moderate respiratory distress on the SAS score or the Down score, and you need CPAP. And if you're 7, or if you're above 7, if you're 8 or above, then you've got severe respiratory distress.
So about caffeine, caffeine is basically, we use it to prevent apnea of prematurity in very low birth weight infants. It should be used in all preterms, but we focus mostly on preterms under 34 weeks. So this should be used at least until the preterm is reaches 36 weeks after delivery. So the caffeine should be given ideally initially before you start oral feeds. It should be given as an IV infusion, not as a bolus, but as an IV infusion. And you have to load it at 20 milligrams per kilogram, and then it's maintained at 5 milligrams per kilogram. And this is best given orally. So as and when you initiate feeds, or you're able to put an NG tube for this infant, then you can switch over this caffeine, and it can be given in milk by the mother or by the nurse in the milk, orally for safe administration. So it's mostly to prevent, it's for prevention of apnea of prematurity.
Great. And this question goes to the Mbale team. Then there's a question here from Sarah. Why was the cranial ultrasound important during the CPAP administration for the preterm admission, maybe?
Okay, so cranial ultrasounds are very important in assessment of a preterm infant. So you want to rule out intracranial hemorrhage. You want to rule out IVH, intraventricular hemorrhage, in these babies. It's been found that the detection of this IVH may be difficult in the first couple of days. So we did a day 1 and a day 3, but sometimes you might still miss the IVH. You might not be able to visualize it. So the best time to get most of the IVHs is at around day 7 of life. So you do that to rule out the intraventricular hemorrhage, which is IVH. This is important because a lot of preterm conditions overlap. So you could be having worsening distress because of the respiratory distress syndrome worsening, or it could be worsening because your baby is having a bleed, or it could be worsening because they've got a pneumonia, and that's why it was important that we did the lung ultrasound as well. So you need to have all these different things, especially in a setting where you're not able to run many blood tests and all these other different tests. If you're able to do an ultrasound for those babies bedside, it helps you to rule out what is causing the worsening of this baby's condition. But also detection of an IVH earlier is very important in management of these preterms, because then you can initiate protocols to monitor this and watch that you're not now developing post-hemorrhagic hydrocephalus in case they have those, and for you to actually intervene early and improve on the outcomes that these babies have. So it might not be directly associated with the management of RDS, but because of the overlap of these conditions in preterms, it's really important to be sure that what is worsening your distress is not another condition that you've ignored or that you've missed out on. Yeah.
Is it possible to calculate the FiO2 from the depth? And I think if you could kindly give us an explanation of, again, what is FiO2 and what is the pressure? And maybe at the same time, Matt, if you could just share that combination slide of how, at least our machines, we can work out what the FiO2 is compared to the flow.
Just to clarify that, so FiO2 is the fraction of inspired oxygen. So if you are breathing room air, so only room air, and you're not adding any oxygen, then your FiO2 is about 21%. So that is for normal room air. The machines, I saw a question trying to ask if the machines calculate the FiO2 for you. That is not calculated for you. So this is something that you'd have to, maybe something like this would be a guide, especially in a situation where you're not doing blood gases. So this would be your oxygen flow meter. So this is 1 liter of oxygen, 2 all the way to 8. And this is your airflow meter. So starting from 0 all the way to 8. So the way you are going to titrate this, the way we've been mentioning, that you will give, if you're giving 2 liters, so as an example, if you're using a diamedical CPAP like the one that we have, and you are giving 2 liters of oxygen, then you'll be giving 6 liters of air. So your FiO2 would be about 36.8. If you reduce this, if you increase this oxygen up to 4, which means you'll also be giving it with 4 liters of air, then your FiO2 is about 57.5%. This is with the estimation using, this is estimating that your oxygen source is giving 95% and not 100% oxygen like a cylinder would. So still, same example, if you go to 6 on your oxygen flow meter, if your oxygen flow meter is at 6 and you're balancing that up with 2 liters of air, then your FiO2 is much higher, as at 76.3%. So this is just that the more you increase the oxygen, the higher the FiO2 you're delivering to the baby. The more you increase the oxygen, the more you reduce on the air that you're giving. So you're giving much higher FiO2s of oxygen to the baby. I hope that answers the question.
Yeah, great. And the pressure?
So the pressure,
maybe we have the diagram. So the pressure is different. So I think the way we do this in Mbale is we think simply. We try and do everything simply. So on Martha's slide there, you've got the oxygen source on the right, and you've got the pressure source on the left. And really, from a very simple point of view, and it seems to work for us, the oxygen source, we titrate it against the baby. She's just mentioned now that that chart she showed, only valid if your concentrator is working at 95%. But for very many of us, our concentrators are not at 95%. They may be at 60 or even 50%. So you might not know how functional your concentrator is. But what you can do is you can increase the oxygen flow and reduce the airflow according to the baby. So if the baby's saturations are below 90%, you know you need to go up with oxygen and down with air. If your baby's saturations are 98, 99, you know you need to reduce your air, reduce your oxygen and increase your air. And so you don't have to be sure about the functionality of your concentrator. And then on the left of the screen, you've got your pressure chamber, which hopefully you're using an approved one, that we know that the pressure of the tube under is actually what you're delivering. And you can titrate that pressure to how the baby looks. So if the baby has got increasing signs of respiratory distress, you increase your pressure. And if your baby's got less signs of respiratory distress, you reduce your pressure. So as we've said, we use the Down score. You can just as well use the Silverman-Anderson score, or if you're in a high income setting, or if you're very lucky here in Uganda, you can use your blood gases. But it's, and we normally adjust by 1 to 2 centimeters, not a big jump, but we adjust by 1 to 2 centimeters every hour or so. So if you go back after an hour and your respiratory distress is still bad, it's more than 4 on the Downs or the Silverman-Anderson, you're going to increase your pressure to 7. If it's still bad when you go back an hour later, you'll increase up to 9, and vice versa. If you go back and it's reducing and the baby is happy, then you're going to reduce it down to 3, and then maybe down to 1, but probably you'll think about stopping that. Great. I'm just trying to go through the rest of the questions. Elvis, you have your hand up. You ask your question whilst I check the rest of the questions in the chat box. Go ahead.
Good afternoon, team. Mine is not a question. I would like to make a compliment on FiO2, especially for resource-limited centers like Uganda and then the health system in our country. FiO2, there is a machine, very cost-effective and very cheap. It can help on measuring FiO2. It's called an oxygen analyzer. So if you're not sure of how much FiO2 you are giving, it can always give you a guide. Then for most of the facilities use concentrators. Concentrators, their mode of action, when you look at how they give us oxygen, pure oxygen, they are going to filter room air. So they are going to suck the room air into their system, filter it, purify it so that they give you some oxygen. Meaning if I'm giving 1 liter of oxygen and then someone else is giving 10 liters of oxygen, the machine cannot get, it's not getting enough time to purify pure oxygen. So at all times, someone who is giving 1 liter of oxygen is giving a higher FiO2 as compared to someone who is giving 10 liters of oxygen by a concentrator, unlike for an oxygen cylinder. So the higher you go, the lower. So that was my submission. Thank you very much. Thank you for the presentation. Very, very informative.
Great, Elvis, that's really helpful. And I think that's really true. The oxygen meters are there. And most hospitals, actually, of late, I think UNICEF gave out a lot of them, but they're not expensive. We're not, as good as you suggest, we're not measuring FiO2 for each individual baby, but I think what is really key, two of the things that you've said, is checking your concentrators regularly. How much oxygen are they producing? Again, in Mbale, we're not very good. We check once a month, but I think most people can do better than us, but we at least know that the percentage of oxygen that's coming out of that concentrator. And like Elvis has said, the lower the flow on the oxygen concentrator, the better the ability of the machine to produce the oxygen. So if you are testing your concentrators with an oxygen meter, you need to test them at 2 liters per minute, so you know the full functionality of your machine. And if you do have time, those oxygen meters, like Elvis has described, could be used to accurately measure the FiO2 for your actual individual patient. Thank you for those suggestions, Elvis. There's a question here then about giving caffeine. I think Martha's already described that caffeine should be given as an infusion, not as a bolus, not IM and in milk, but it's asking for clarification on which fluid you can use for giving the caffeine infusion.
Thank you very much. Caffeine is given in fluids, depending on the type of the fluid that you're giving the baby. Mostly on day 1, in our preterm babies less than 1 kilogram, we always give them dextrose 5%. Still in day 2. So depending on the type of the fluid, we have a neonatal fluid, we have dextrose 10%, we have dextrose 5%. So depending on the type of the fluid that the baby is on, so that's the same fluid that you will put your caffeine, and that is the loading. You put only the loading doses on fluids, but the maintenance dose of caffeine is given orally in feeds. You give the mother to mix with the milk, and then she gives using a nasogastric tube.
Wonderful, thank you, Mary. Okay, I apologize if I missed anybody's question. I've tried to keep track on that. Is there anybody else who feels I've missed their question and just wants to raise their hand and ask it, or have we managed to get everybody's questions? It's been a really beautiful discussion today. So many great questions, and yeah, so many good answers. So thank you to all the presenters for doing that. I think the questions have been many, but they've stopped appearing in the chat, and I don't see any hands raised. There were a fair number of questions about sharing the presentation and sharing the recording after. So Jeanette is on the call with us, who oversees the Scale Neonatology program. And anybody who's registered for this session today, even the people who have dropped in and out because of connectivity, she will be sharing with you the presentations both from Harrogate, from Dr. Amir, and here from Mbale from Dr. Martha and Sister Mary. I want to appreciate all of you for attending. I was trying to watch the number who were joining. I think we hit 178, possibly more at one point. So this is a really great platform for sharing knowledge, sharing experiences across Uganda, south to south, but also from north to south. And I think we've all learned a lot from our 3 presenters today. Next Scale Neonatology is in June. That'll be Friday the 13th of June, which I believe they say Friday the 13th is unlucky for some, but hopefully not for us on that day. And we will be sending, or at least Jeanette will be sending out more details regarding that presentation closer to the time. And I will probably be chasing some of you to give that presentation closer to the time. So I can see a lot of appreciation. I'm looking for the questions coming down in the chat, and yeah, reiterate the appreciation for the two fabulous presentations we've had today.